We're going to move on to our next session. This is improving care for the disadvantaged. There's hope on the horizon. This is the third year we've done this session. And the first year, I think we identified a lot of issues. And the second year, we tried to find some solutions. We're going to continue to do that. And I think we've assembled an outstanding team of experts here to discuss this. And remember, this is an iterative process. You can't make changes overnight, but you got to have the discussion, and that's what we're doing. So I'd like to invite Dr. Megan Tracci to come up first. She is not only a vascular surgeon, she's a lawyer too, and she does a lot of stuff with advocating for our patients in Congress. Megan.
So before you have a bunch of incredibly bright people and spectacular clinicians and leaders talk about what we should actually be doing for patients, we're going to talk about how we make this possible. Is there any hope? It's a big day, election-wise and politically. People are thinking about that. It's going to be a big year for us in this last run in Congress. I'm going to talk a little bit about whether there is a hope going forward and how we do this. So what's the question? I think there's a policy path forward. What do we need to do to help support this good work? And how do we do it effectively? So what do we need to do? Well, we've been talking for years about fixing Medicare payment. There will be a stretch run to December 20th, where we might be able to do that in the short term and really talk about starting to build on doing it in the longer term. There's room for improvement around the edges in frankly, bad policy that's standing in the way of doing good work. There's really room, and we'll talk about this in this session, for disease and population-specific initiatives, and really an open door going forward for some broader reform. So just setting the stage, most of the people in the room are familiar with this. Medicare payment has fallen behind the cost of providing care. This has perhaps fallen most heavily on the shoulders of that dwindling group of people who are still in independent practice, but who in our field, particularly in PAD, are a critical part of the safety net for providing care for patients. And we forget about this a little bit. Why is this feeling more painful? Because it's more painful. 20 years of losing ground against inflation, actually losing real dollar value in the payment for the services we provide to patients. We forget about how much value we bring. We provide life and limb-saving services to these folks. And ultimately, to some extent, the employed folks have been a little bit sheltered by the fact that spending has continued to grow on the hospital side. But as those belts are tightened, we feel and our patients feel the squeeze on the resources that we need to provide them good care. So we need to look at avoiding further cuts and also look at the fact that we talked a little bit about value-based reform, but anything in that realm going forward has to come with sustainable funding. So how do we do this? Looking at vascular care, the care of vascular patients, and particularly PAD patients, has been hit perhaps harder than almost any other sector of healthcare. Ironic, since this is an incredibly complex, needy in many ways, socially and medically, group of people, particularly, again, on these procedures performed in the outpatient setting. Look at the concept of underwater codes, where you're getting paid less than your supply costs for providing care to patients. How long can that go on? Probably not forever, right? So I love the most interesting man in the world. Ultimately, we need to stop these cuts. That's a multi-part thing. Part of this is triggered by these just big, slow-moving budget neutrality things and caps within Medicare that as costs rise in one sector, everybody else takes a hit. This is hit particularly hard in the outpatient setting, as mentioned. And we look at the sustainability of payment for physician services in this space. They really have not been indexed to inflation, unlike every other sector of healthcare, which has not only been indexed to inflation, but beaten inflation over this period of time. So as the overall healthcare spending belt tightens, our belts have tightened about 6 notches to everybody else's 1. It's hard on patients and it's hard on people providing critical services. So is there hope in the short, medium, and long term? Yeah, absolutely. This is why we need to have doctors in Congress, right? So I always forget to say one of the things that you can do to help fix this is to be an informed physician who runs for Congress and wins. And introduces legislation like this. So this is one of the things that may move before the end of the year. Every one of our societies has the opportunity for you to write letters to let Congress know that this is incredibly important to put in that end of the year package. It is urgent. So it stops the cut and gives us not a full inflation adjustment, but half of the Medicare Economic Index. It's on the right track, it's temporary, but I think it really marks an acknowledgement that not keeping up with inflation is not sustainable. And there's some improvement around the edges. There is a broad bipartisan support behind prior authorization reform. Again, something that delays and denies care for patients, drives up the costs of health care for things other than actually taking care of patients. Dumb nickel and dime stuff, no fees for EFTs. Why on earth would you pay a fee for getting electronic transfers of funds? Do they expect to be paying you in bags of pennies? I don't know. But there are some opportunities here. There's some work around non-competes, workforce, other things that support our workforce and actually support our autonomy and leverage within the space. Even things like collective bargaining that hadn't necessarily been discussed in years, but ultimately have been broadly adopted by our trainees. I think there's a generation of physicians who are moving into employed circumstances where this is actually not banned and who've expected that type of representation in training and likely will going forward. So, got some experts here, again, talking about opportunities for population health, whether it's around conditions like PAD and the ARC Act, looking more broadly at-risk populations and prevention, the whole continuum of care. And there's room for broader reform, antitrust enforcement to address some of the consolidation, both of providers and of payers, that has driven up costs within healthcare. There are some broad reforms from capitation to single payer that are probably on the table in the next 10 years. So what are my 2 cents on the content of it? If we're going to reform, let's reform thoughtfully. We always think about value as cost and quality. Don't prioritize cost over quality. Don't inadvertently penalize safety net providers for serving at-risk communities that may be expensive. One of the things that we ignore is that we talk about healthcare spending, and that partially obscures the fact that, yes, the U.S. has higher healthcare spending, but it has much lower spending on other social services that form a lot of that safety net in other countries and other systems. And we forget that other part of the 360 degrees. Don't redline communities this way. And don't lose sight of our real goals of care. So how do we do this effectively? We target Congress, the agencies, the states, talk to the RUC, go to CMS, lobby Congress. What is our access to that? It's our PACs, each of our organizations. Give to one of them, give to all of them. We have to identify the problem we want to solve. Don't just go in there and complain, and bring solutions. And this is where Dr. Beckman's data is incredibly important for making this crystal clear and doing that elevator speech. Good messaging, grassroots, grasstops, and coalitions. So there are different pillars of effective advocacy. Again, the agencies with regulatory advocacy, federal legislative advocacy, going to Congress, grassroots, what you can do from your home in your office in that 5-10 minutes you've got free, and political advocacy by our professional staffs. So we love targeting congressional champions. There's a Docs caucus in Congress and a handful of other legislators who really get this. They are in the weeds, they're supportive, they're working with our groups and our staffs to help craft solutions. Then we look at targeting key committee leaders and staff. Here are the 4 big committees in the House and the Senate, and obviously working with CMS. What's the PAC? The PAC facilitates access in DC and locally. It is not a quid pro quo. You don't write somebody a check for a piece of legislation. It's a little bit more nuanced than that, but it's important for access. You got to bring both the problem to the table and make it crystal clear in defining it, but you got to bring a solution. The concept, you got to figure out what your constituency is. Who is this going to make happy in a congressman's or a senator's district? Whose problem is this going to solve? It's helpful if you can propose legislative language or work to do that, so you don't leave a big pile of work that never gets followed up without urgency. And it's even more helpful to professionalize the operation by bringing some strategy. How do you move this through Congress? How do you pay for it? How do you take money from one part of the system and apply it to another? You professionalize that messaging. You target messaging to our own folks to help get that grassroots moving and get people speaking to the people who need to hear it. Talk to our lawmakers and talk to the public. And I would commend our societies for working together to do a better and better and better job of that over just the last 2 to 3 years. Again, grassroots, PAC engagement, click on this thing. You can send a letter in under 90 seconds, and it matters. If you've got a little bit more than 10 minutes, you can start reaching out to your local delegation, your congressman, your senator, and build a relationship so you become a trusted voice and an expert in your district, and someone the society can call on to pick up the phone when we need somebody to step up. And again, this terrific coalition building by our societies, the VIVA Foundation, both solving problems and working out our differences in private. So coalitions and collaboration across societies is going to be absolutely critical to solving these problems and rowing the same direction going forward. So this is a marathon and not a sprint. If we're going to help support all the really good work that these folks are going to talk about, this is what we got to do. Thank you for the invitation.
Thank you, Dr. Tracci. That was a fantastic overview and a lot of work to do. Last year, we introduced the concept of the PAD Collaborative and the amputation heat map. And now Dr. Beckman is going to tell us more about it and how to utilize this tool.
So I'm going to do a little bit more introduction. First, thank you, Dr. Tracci, for setting me up so nicely. That was very kind of you. I think, and I'm going to endorse quite strongly, that when we work together, we work stronger, better, and we're more effective. And so the AHA back in 2015 convened the vascular community to come up with sort of a roadmap for how we should try and improve vascular disease prevention, detection, and treatment. And every organization that you guys participate in, and then also regulatory agencies and the NIH and insurance companies all came together to try and create a more global way to approach vascular disease and improve outcomes. They focused on 5 important things, and basically this was a strategic oversight plan that will later come to fruition with the PAD collaboration specifically for peripheral artery disease. But the 5 things were to advance science, elevate awareness, enhance professional education, improve healthcare delivery, and advocate for policy. And I'll make the point here that the American Heart Association really is a public charity. It's a healthcare organization for the public. It's not an organization that is representing any individual kind of physician or surgeon. The science portion is obvious. I think public awareness is going to be key for our battle going forward, right? If you want to improve the care of the public actually has to be engaged. They have to know that there's a problem. They have to want to participate because they feel like it could be them or their family members. And when we have more than 10 million people in the Medicare population of peripheral artery disease, you know that every family in America is somehow touched by this problem. Enhancing professional education is also incredibly important, right? How many of our brethren and sisterin, is that a word? Who are not in this kind of audience know what an ankle brachial index is and when to get it, or even how to feel a pulse now. Improving healthcare delivery is a lot of what Dr. Tracci was talking about, and advocacy. When we advocate for our patients, our message is very strong, right? Everybody else advocates for themselves, and there's nothing wrong with that. We're supposed to do that in a representative democracy like the one we have. But when we advocate on behalf of the people who are not doing as well and need help, I think that gains particular power. So one of the things that happened right around the same time as we were moving in to create more specific programs was that there was an article in ProPublica by Lizzie Presser that basically discussed the black amputation epidemic in the United States. You can see where there is a huge number of amputations. This was back about 15 years ago now, although it doesn't really change very much, and where the enslaved population was. But I'll make the point that geography is incredibly important, and it's not just in this area. It extends to the major urban areas that we think have really great access to healthcare as well. And this makes the point quite clearly. There is no place in the United States that is safe. Even states that do it really well have areas that don't do revascularization prior to amputation. Right? This is terrifying. This just tells us that there are people who would rather move to amputation than they would rather try and save a limb. And so this happens across the United States, and so we all have a role to play in trying to improve advocacy and get the right things done for the right patients. And in fact, this is just specific numbers. 30% of patients do not get arterial testing prior to major amputation. And you can see, even of the tests that are done, ABIs are done in fewer than half the people who end up getting some kind of amputation. We're not even checking to see if it's a blood flow related problem. All right, now I want to make the case that geography matters a lot, and we talk a lot about the South and the Southeast, but honestly, this is everywhere. This is the South and North sides of Los Angeles. Rural locations have just as big a problem, right? Rural, poor, minority populations all do not have great access to healthcare. And if you just take a look at recent geography maps that were published, one in the Journal of Vascular Surgery, one in, I think it was the Journal of the Society of Coronary Angiography and Intervention, 30% of the population in the United States does not have within-county access to vascular surgery. About the same percentage does not have access to interventional cardiology, and about the same number does not have access to interventional radiology. And it's not like where there's a surgeon, there's a cardiologist. It's either a desert or you have 7 million people in the same hospital. And so the distribution of people is incredibly important, and there are so many people where there's nobody. And so one stat that I just keep in mind is that one person, Felucio Fakarides, who moved down to the Delta in Mississippi, reduced amputation rates in his area by 50%, because the number of people who are willing to try and do intervention went from 0 to 1. So you can just take a look here at what are the key factors that determine who's going to have an amputation or revascularization. And you can see that amputations vary based on who you are when you walk into the office. It's always worse to be poor. It's always worse to have Medicaid rather than private insurance. It's worse to be non-white in the United States. Here are some of the social determinants that Lizzie Presser identified. None of these are surprising to anyone, but basically, I think there's a lot that has to do with where people live and the access to health care. Eric Soszemsky demonstrated to us that when you get the same kind of health care and then you factor in morbidity and where you live, there's really no difference in outcomes, which just tells me that you need to have access to health care, and that's really part of the big problem. All right, so I wanted everybody to be armed to be able to walk into their local representatives, and I think the two ways that you can use this information is to create accountability with information. So this is a national amputation map by state and congressional district. You can walk into your congressman or woman's office, and you can say, in your district, you have this many people getting amputations. What are you doing for us? This is Texas, where I live now. You can see there's a giant splay. It's always better to live in a big city than a very rural area. And you can see the amputation rates vary between 85 per 100,000 all the way down to 27 per 100,000. That's nearly a fourfold difference. That's just a massive variation. This map will tell you every single district in the United States. And we all, again, blame, just making this really clear, we blame some location on this, but look, even though the top two areas of amputation at 170 per 100,000 population are in Mississippi, number 3 is in California. There is no one here who walks away scot-free, and so you can walk in and basically have an elevator pitch with numbers and specific accountability. That's the way to start the conversation. In your district, this is happening, and you're worse than 70% of the people in the United States. Now, 70% of your fellow representatives. So the way that I look at this, and by the way, this is available online, free, just look at the PAD collaboration and amputation map and it'll come up. Data is the power to hold the powerful accountable. Real numbers go much further with non-experts. Using congressional districts is an entry point to a conversation with legislators and regulatory agencies because you can pinpoint the problem on them. The data will be updated again soon, so it reflects more recent stuff. There was a little bit of a pause because the pandemic numbers are not really reflecting usual reality. With that, I'll say thank you very much for your attention, and obviously it's a pleasure to be here amongst this august panel. Thank you.
Thanks, Josh. You know, and it's great to see. We brought up the concept 3 years ago about this, and you saw progression. It's an iterative process, and I think we've seen it grow. Next, I'd like to invite Dr. Vincent Rowe, who is the Chief of Vascular Surgery at UCLA, to talk about how we can take the principles of safety net hospitals and make this a standard of care in all communities.
Hey, thank you very much. Really happy to be here. And the two prior speakers, Dr. Beckman, Dr. Tracci, both brought up, very collaborative points, very interesting points that kind of mesh somewhat into my talk, and so you'll see some overlap, and we'll go from there, and hopefully it will be a starting point for some additional discussion. I have no disclosures for this talk. So safety net hospitals, as I was preparing for this talk, I was surprised at how many definitions there are for safety net systems. You could just use some of the global terms to say that they serve a high proportion of low-income patients, those that have more Medicare or uninsured, and a lot more Medicaid. And oftentimes they have a lot less private patients than what we see in most hospitals. So it is a different type of system, and oftentimes they work within our urban areas, but they can be rural as well. So how do we take these principles? And I thought this was a very difficult question to answer. I could have some suggestions, but it's really hard to answer because Dr. Beckman kind of touched on this. Things are different throughout communities. So we take care of a patient from somebody that lives here, it's going to be completely different in terms of our outcome for someone that lives here. The social determinants are real, and they just start on a numerous amount of levels. If we look at just how much money people make, this is from the Federal Reserve, you can see the difference between black patients, white people, and black people in terms of just wealth on an annual basis, and that gap has continued since 1989 to 2019 when they reported it. If we look at based on education, those in the orange, you can see with the GED education, their annual income quite low compared to those at the very top, like most of us that have a postgraduate education, and bachelors falling somewhere in between. So there's a significant gap just based on education. If you look at life expectancy, survival rate, this study in JAMA took the patients that were in the 5th percentile of income in blue and those in the 95th percentile in red. And you can see the differences in terms of their life expectancy at 63. And really the gap starts to open up when people are about 50 years old and extends all the way down to in their 70s and 80s. So there's a difference in probability of survival just based on your on your income level and where you stand in terms of the poverty line. And your educational level. This is a good slide to show your kids, to tell them to go to college. What will happen? They'll live longer. Men that are 47 years old, less than high school education, live at about 47 years as compared to those that have had college education up to 56. And the same type of thing that we're seeing for women in this age group. So the patients that we're dealing with in the everyone come in, the safety net systems, it's going to be very difficult because everything is so different based on education, wealth, and all these other factors. So it's going to be very hard. These are some of the solutions, and again, these are just suggestions based on what I was able to come up with in preparation for the talk. The hospitals are big players. Dr. Tracci talked about all the issues with reimbursement and Medicare and so forth, and that is a really big component of it. The hospital reports that comes out, the cost of caring, this one came out this year in 2024, and there were multiple complaints from the hospital side. They said that inflation has grown much faster than they're able to get their reimbursement. Also, the cumulative underpayments from Medicaid and Medicare are now up to almost $500 billion over the last 4 years as compared to prior decades. So it's really significant. And then if you look at the premiums for insurance companies have grown, and they really point the finger at the disruptive nature of the insurance companies and say that they're the ones that are causing a lot of problems. Like what? What we see in our offices. all the money that they're having to spend, the hospitals are having to spend on getting prior authorizations, what they're having to do to appeal these authorizations, the delay in care that it causes for our patients as we try to get them authorized, all the times they're rescheduled and having to cancel their cases. The denials are increased, as well as all the money that it takes and time that it takes for your hospital staff to take care of these denials and subsequently get them overturned. So the hospitals point the finger at the insurance companies, and they kind of rightfully so, but still, it's a significant problem which I'm not sure how to fix. At the rural level, you can see even the rural hospitals, a lot of them have a negative margin, and they're functioning at a loss and oftentimes are subsequent to close, which creates a whole nother issue for patients out in that area for access to care. What about the societies? I think Dr. Beckman said we need to work together. I completely agree. American Heart, American Diabetes, all the ortho societies, especially when it comes to limbs, we need to work together. Patient education is going to be very important. And I think screening, we briefly just touched on screening, and we're starting to see some data that shows that screening is advantageous. Right here in Nevada, they looked at those with Medicare Advantage, and they screened them over the last 10 years, and they saw that when they identified PAD in those patients early, they just didn't survive as long. So maybe this is more fuel to say that screening does help, not only necessarily for limbs, but for lives. We briefly touched on the ARC Act, and I had the benefit of actually digging into this whole act and finally meeting Congressman Payne. He was the one that basically wrote it many years ago, and it's been working to get its way through Congress and get approval. Unfortunately, he's had an untimely passing, and he suffered from some of the same diseases that he was advocating for, end-stage renal disease and diabetes, and unfortunately, he passed away, and hopefully someone can take up that mantle and move it forward, because I think it will be beneficial. What about us, the docs? What can we do? Well, one, and especially in vascular surgery, we're not distributed very well at all. If you look at, we have just over 3,000 vascular surgeons. Most of us are in the counties that are urban related and not rural. And in fact, we need to get better distribution of us out into the communities, because those patients have an issue not only with getting to the hospitals, but getting to a vascular surgeon or a vascular specialist. We should probably try to work better in teams. This is kind of my own extrapolation from the BEST trial in terms of what I think it represents. We said, hey, let's take a look at just the disparities of BEST trial. We know the BEST trial randomized endo open, but how did the Black and Hispanic patients do compared to those that were white? And I think one other thing we could do in the future was say, how did those that were treated in safety net hospitals compared to those that weren't? Either way, when we finally looked at it, we saw that the patients that were non-Hispanic white compared to those that were non-Hispanic Black or Hispanic, here are some of the comparisons. The hypertension was about the same, but slightly higher. Higher levels of end-stage renal disease in those that were Black and Hispanic, and diabetes was significantly higher, especially in those that were Hispanic. Oftentimes, those patients presented with more Wi-Fi grade 4 and had a lot more infrapopliteal disease. But when we did the final analyzation, no difference. No difference at all. Was the disparity solved? I don't know. Is it because of teams? Is it because of the study? Is it because we selected? I don't know. But we have to start to think about the fact that maybe this is a way for us to solve this long disparity that's present amongst all of our patients. And finally, the data. This was the distribution of patients in the BEST CLI trial down here. You can see the breakdown, 20% Black, 13% Hispanic. And if we look at the 2020 census, you can see Blacks considered high risk. 12% in the United States. There were a higher number in the trial, so they did capture those that were high risk. Hispanics, though, 18.7%, but only 13%, so there was a little bit of a gap there. And so we went and we said, okay, what's going on in our data, large data samples? We took just the PAD group in the VQI and the PAD group in a sample of the NIS, National Inpatient Sample, and said, what do we see? Well, here we see 20% of Blacks in those databases, so they're actually very good. They're giving us some data that we think could be helpful. But here in the VQI, we're less than 10% Hispanics. So what could we do to solve that? Perhaps get better implementation, more structure in those hospitals that are taking care of a lot of Hispanic patients so we can gain that data and try to get everything together. So finally, I think we have to educate our patients, screen hospital payers. I have no idea how to fix it. It's going to be a big job. Societies, I said screening, and physicians work as a team, and data. Hopefully we can get that same structure to safety nets hospitals. Thank you.
Yeah, and great talk, Vince, and a lot of things to think about. We're going to take a few minutes here to do a panel discussion, and so I'm going to start with, for Dr. Tracci, we just heard from Dr. Beckman and Dr. Rowe, what additional things do you need in the armamentarium to go advocate to Congress?
So I think Dr. Beckman's done a terrific service in terms of advocacy. We really need to marshal data. It can't be purely anecdotal. It can't be whining. And we do need to bring the solutions. But I think that lets you really bring the point to a focus. I think as individuals, if you're engaging in advocacy, and I'll speak from the advocacy perspective, being able to make things real within a member of Congress's actual district, they know what the hospitals are, they know what the communities are. Believe me, they know all the zip codes, where the borders are of all the streets, et cetera. You tell them that you can take that data and tell them stories that bring it home to the impact on their hospitals, probably the biggest employers in town, a significant weight, but also the people in the community. So I think that making that connection and bringing sort of an urgency and immediacy and a polite in-your-faceness to it is important. So you can do it quickly by a letter, you can do it by a phone call, you can get on social media, that really stresses them out. But if you can actually get there in the district or in person, that's incredibly impactful and very much worth your time.
Dr. Beckman, we were talking about the heat map and using that, and how powerful, has it been used yet? Do you have any examples of this being used to go to members and let them know?
Oh yeah, it's been used multiple times. I think there was actually a pretty significant amount of movement with the ARC Act. It was still being modified a bit until the untimely passing of Congressman Payne. And there have been lots of people who have visited offices, and the first answer to your giving data is, oh, and then they want to know immediately how they're doing compared to their other people in Congress. So obviously the people you want to have this conversation with are either people who are naturally interested in this topic, like the Congressional PAD Caucus, or people that you don't think would ever be interested, but certainly don't want to look worse than everybody else in Congress. So, the opportunity to say, the amputation in your district is 100 per 100,000 is a number, and then you can say, you're in the bottom quarter of the United States. There's something wrong in your district. That's a very motivating message, right? Because the last thing they want is for, say, their opponent in the next primary or general election to be able to say, your congressman is allowing more legs to be chopped off than almost everywhere else in America. That is not a happy message for anybody. So I think it's been used a bunch of times. It's been used a bunch of times also with HHS, so they know where there are problem spots. And there's some demonstration projects that I think are underway, but I don't think we've used it enough, and we have many more opportunities.
And for Dr. Rowe, the Congressman Payne was a big advocate. Do we know who's going to pick up the mantle, or is there anybody picking up the mantle for him that anybody would know of?
I'm not aware. I mean, I mentioned this, the way that it hasn't moved through, probably about 2 years ago when I gave a talk at Midwestern Vascular. And I remember talking to Pat Garrity afterwards, and we were discussing, the role of it. And I kind of wanted to dig in there at that point, and dug in all the way to when I was standing next to him. And it was interesting to see how he was stricken with the disease at such a young age. I don't think he was 50 when he passed. And he came into this meeting in Washington and had just finished dialysis. And you know what post-dialysis patients look like. And he was suffering with everything that he had gone through. He was wearing a walking boot, so he most likely had either an ulceration that was healing or offloading something that had just been debrided, who knows. But I don't know. I've tried to, since I mentioned it in talks before, I said, let me dig in. I haven't dug into the point to know who's going to take it over. Maybe Dr. Tracci does. So go ahead, Megan, and comment on it. But yeah, it's significant. I think it's one of the keys to help us with this whole fight. Not the only one, but it's perhaps one of them.
Say, anyone who's got the bandwidth for advocacy and lives in one of those red districts is an opportunity. Going face-to-face to meet staff and members is an opportunity. You learn things about them. You learn that they have a parent who's struggled with, diabetic foot problems, somebody close to them, that their staffers have been dealing with it, that somebody's come up in a community that's been disproportionately impacted. Those are really the hooks that you need to cut through the noise of all the pressure that they feel to be dealing with so many different issues.
All right, well, we'll have more time at the end of this session. I'd like to invite Dr. Elina Quiroga from the University of Washington to discuss, have we made any progress with combating bias in research?
Thank you so much, Dr. Singh, and I want to specifically thank the VIVA board and you for making the time at the Global Theater today and everybody that's in the room to talk about this such an important topic. These are my disclosures. So I was asked to talk about how we make any progress, and for some reason today I'm very, very optimistic. I want to say that for being a vascular surgeon, we always talk that, or anybody that works in this arena, you have to be optimistic. You need to think that you can make the patient better. So we're going to approach this topic with the same lens. And I have been talking about this for years, and we have talked about how there are so many embedded systems in the healthcare that we deliver every day that are biased, and they make different outcomes for our patients. But there has been some change. So one quick example is the Get With The guidelines for the American Heart Association heart failure. As you remember, these are guidelines that are in place, so you can go, you put a calculator, you see how risky your patient is, and based on that, the patient gets admitted to the ICU, CCU, or a medicine floor. And we know that this is ligated to the outcomes of the patients better, and the hospitals get actually compensated for following these guidelines. So this is the calculator. You use several factors. And one of the factors, as you can see here, is race. So being Black automatically makes you 3 points more healthy, automatically, and less chances to be admitted to a cardiac floor and to have appropriate care. So when this was asked by the investigators of a paper that was looking at bias in research, the American Heart Association could not provide a rationale for this adjustment. They looked and they couldn't find why, and this is a clear example of bias. But things have changed. So the American Heart Association came with a actually more appropriate prediction equation for risk assessment on cardiovascular disease, and is incorporating cardiovascular kidney metabolic health, a completely different concept that we all can agree. And also, they took away race, as we know that is a social construct. So little of progress here. We have talked about the GFR equation, one of the most clear examples of discrimination, how it doesn't incorporate the patient weight, it doesn't incorporate the muscle mass, it just incorporates the patient age and the creatinine and the gender. So if a patient has a creatinine of 3.4, it's identified as white, the GFR is 18, so automatically you get referred to transplant for evaluation of a kidney, and you get sent to a surgeon or a physician for access creation. However, if the same patient, exactly the same patient, gets identified as Black, the patient GFR is 21, so this patient is not going to be referred to transplant, is not going to get an access early, it's going to have worse outcomes. So most hospitals and more healthcare systems have eliminated race, but there are some places that still do it. The NIH have made some call to action. You know that now they are requesting an inclusion of women and minorities as participants in research involving human subjects, and I really like the fact that it says in a manner that is appropriate to the scientific question. This should be about tokenization of a population. It should be about excellence in scientific research. Still, we have not seen the result of this yet. So what's going on in our sphere? The Elegance Registry is I have to disclose that I'm one of the PIs of these trials, is an example of intentionality. When you try to enroll a patient, we're looking about enrolling all the minorities and women. So at the PI level and at the population, we're more than 40% minorities and women in the registry at this moment, and we're looking at the real-world post-market outcomes of patients with drug-eluting technology. Another example, very quick example, is, and these next two have the same name, and I found that very interesting. It's called the Warrior trial, that they are looking at the outcomes on women with non-obstructive coronary artery disease. This is still ongoing, and my understanding is they're still enrolling, and the same with the Warriors trials. They're looking at if we should repair aneurysms in women at an early stage compared to the using the same for both genders. So a couple of quick examples, and I said that I am an optimistic. Still, I think that we should not get complacent about this topic. So you may be asking yourself what I can do. I am not like in a place that we can have a clinical trial. I cannot do anything. And I think that there's a lot of things that you can do still to help. And the first things, maybe today you can vote and you make your voice heard today. I hope that you really did, because if you're not for Vegas, you're a little late. But I have a particular interest in language. As you know, English is my second language. And at our institution, we have implemented a cultural competency M&M. And one of my favorite modules is the one about stigmatizing language. And let me walk you through a couple of scenarios. This is a note as it was written by one resident in the ED, and it's talking about a 38-year-old homeless patient with a history of meth abuse, arrived restrained with a gunshot gun to the right arm that occurred during a drug deal. So we talk about this statement and how much bias just that statement is implying in the whole team. So we revised it to something that we all consider that was a little more appropriate to the clinical question and the patient status. The patient is a patient that was brought by the medics with a gunshot gun with a tourniquet placed at the scene. This was a recent example from my clinic. One of my residents go to see a patient and does a statement. Patient with a history of renal disease due to heroin, referred to AV graft placement, and after that the resident put, of note, the patient had been previously incarcerated. And we talk a lot about how that statement, even if you don't want it, automatically put bias on you. So we revised it to a patient that have AA amyloidosis, that's a medical term, dialyzing with a line that referred to us to discuss vascular access. So we know that bias or stigmatizing language can change the attitude of providers toward patients and can negatively influence the perception and actions of subsequent healthcare providers, can lead to lower quality of care, and more important, can perpetuate healthcare inequities and can broken the trust between patients and providers, especially now when they can see our records. And this is a very quick example. They did a study in a psychiatric meeting. They give the same vignette to two groups of people and to physicians, and the only difference was there was substance abuser versus substance disorder, exactly the same clinical case. And the physician who read the vignette with the term substance abuser agreed more than the person was personally culpable and should be punished, less that the person needed treatment. Just changing a word impacts so much bias on you. So try to, when you're writing a note and talking with other people about your patient, place emphasis on the persons instead of the disability, illness, or other characteristic, and avoid this unconscious dehumanization and marginalization of patients. And this is quote from a paper, and I know that a lot of things that we said might be just perceived as simple the way that we're tough to speak. It's worth questioning whether the linguistic pattern have become normative, such continuous as such. And much of the language that we have learned and used come from an era when paternalism was the dominant paradigm in patient-physician relationship. The fact that this is normal does not mean that it's also not harmful or denigrating. So just to close, I hope that we can acknowledge that biased medicine exists. We're making progress, but we need to do more. Critically evaluate the patient we learn and we teach and the way that we talk, and recognize how our bias can impact the relationship with our patients. Thank you so much.
Thanks, Dr. Quiroga, and a very powerful presentation. Finally, we're going to have Dr. Bryan Fisher put it all together, goals achieved and goals we're still working towards.
All right. Thank you again for an amazing conference. This is, again, one of my favorite conferences of the year, and it's actually one of my favorite talks that I give during the course of the year, because I think these are some of the folks that obviously are the most vulnerable and need our help the most. So having this conversation at this level is obviously very important. So when we look at, some of the action items that are needed for when it comes to disparities in care and amputation prevention, we can break it down based on sex, race and ethnicity, and then socioeconomic status. I'm not going to go through and belabor the things that have already been spoken about before, but you can see that it takes a stepwise approach to be able to address these patients in complex socioeconomic environments, and also again, based on race and ethnicity, based on the history of the country. That's just simply a reality, and you hear that time and time again. When it comes to socioeconomic status, again, we need to reconcile medications and do things like optimizing guidelines for treatment. We know that whenever we have patients on certain medication protocols, they tend to do better. We know that from the cardiovascular space the most. So, I want to get into who's doing it right, because we have a ways to go, but there are some folks out there that I think have really taken the lead when it comes to tackling disparities in our country. And as everyone knows, Felusu Fakorede always comes up. This is someone I've had the pleasure of going to Congress with on several occasions. And the work that he's done in Mississippi, in an area where most people wouldn't want to go and live professionally, and taking upon himself to provide expertise to those patients, is something that's needed throughout the country, and it's something that we have to really cherish and really honor. And Dr. Fakorede is still young, but has plans to try and expand and do more work for these patients that are truly vulnerable. But what really stands out to me is, I was at a conference a couple of weeks ago, and what really stood out is there was a patient that actually was in another part of the country, actually in another area of the Mississippi. And what was Felusu able to do is get that patient to one of his colleagues, who happens to be, again, in a different state, same specialty. But that's what we need and when it comes to collaboration and truly treating our patients optimally. How is he doing it right? I would say a dedication to functional limb preservation is obviously the most important thing. We talk about treating limbs and saving limbs as though everyone can do it. And to be honest with you, from a technical standpoint, this is truly a very specialized field. This isn't something, I think the work that I do, I don't think that I could do it if I dabbled in it. It's something that I've dedicated my career to almost full time, and that's the way that we truly make a difference. Again, that clinical and interventional skill set is absolutely key. And then finally, we discussed this earlier regarding the relationships with the community, legislators, and then having local and national support. I love the idea of having a heat map and being able to go into one of my representatives and say, here's the results that you're getting, and how can we actually make a difference? And I agree with what the other panel members said earlier, is that we can't go in, it's an emotional topic. This is something that we hold true to our heart. As an African American, I know the results and I know the disparities that occur in my community, even when socioeconomic status isn't factored in. And so it's something that truly it gets me emotional. It's something that I'm very passionate about. But unfortunately, passion is not gonna really move the needle when it comes to getting legislators on board and doing actionable things. There has to be actual data, and I love the fact that we're actually putting that data together now. So some of the other things, again, Representative Payne, we missed him dearly. The work that he did to help push forward the ARC Act was monumental, and that's going to be it's a tremendous loss. And as we've identified up here during these talks, we have to identify someone that's going to pick up the mantle, because you have to have a champion. Again, you have to have physician champions, you have to have legislative champions, and he was certainly one who we're greatly going to miss. Again, those relationships with the community, legislators, local and national support is absolutely key. So the Association of Black Cardiologists is another group who is doing things the right way. I think the ABC PAD initiative and getting other societies involved, again, is going to be key to moving the needle forward. It's going to take a collaborative effort. The results of what we do, whenever we get it right, identifying some of the roadblocks and some of the things that we don't think about when it comes to patient care. And we know what it looks like when the patient's in the hospital, but what about when they go home? What about when they have a single leg amputation, and even if they have a prosthetic, are they going to be able to get down things like stairs? Having something simple, a resource like having a ramp, will make a monumental difference in this patient's life. Again, having the heat maps is key, having data. We can't move the ball forward and really move the needle if we don't have that data to back what we have. And again, this is one of the most famous heat maps out there, and it should continue to stay in the forefront. It talks about the rate of revascularization, in the year prior to amputation or PAD. We know that in communities where patients are offered angiography and a vascular workup, they obviously tend to do better. The likelihood of amputation goes down. The time to amputation goes up. So these patients have an opportunity for functional limb preservation and can have an opportunity to continue to live. We know that when they have an amputation, that most of those patients, or half of them, are going to be dead in 2 years. And when you get to 5 years, that mortality rate is abysmal. It approaches that of things like esophageal cancer and breast cancer. Okay. All right. And then, when we talk about these things, I also like to talk about why we're here. And again, this is a video from earlier. If we can turn the volume up. What does this mean? We have to listen to our patients. And again, you can see this is a white patient. He is lower socioeconomic status. He's already been to another hospital and has his contralateral limb amputated. And what can we do here? This is a patient with breast pain who, with a small ulceration, can't sleep at night. He hasn't slept for the past 5 months. There's an opportunity, if we listen to these folks, we can actually make a difference. I'd like to say that collaboration hits different these days. This previous generation, the people that came with the idea of VIVA, this very conference, came with the idea that different specialties would come together with an equal representation and a common goal of making a difference when it came to cardiovascular disease. I think this is monumentally different than what the landscape looked like when I was in training. The idea of collaborating with another specialty like an interventional radiologist only happened if a vascular surgeon didn't have that skill set. Now you have a robust skill set amongst the different specialties, and all those specialties coming together to make a difference. On top of that, I think when we add accountability, when we have a lack of variability when it comes to amputation prevention in each one of our hospitals and each one of our states, I truly think that that's when we'll be able to make a difference. Again, this is what collaboration looks like. We live it in our daily lives. These are friends of mine. These are both interventional cardiologists. Traditionally, we're taught to be enemies. But in today's world, no, we work together. These are two of some of my closest friends, and I value what the knowledge they have and what we'll do to move the needle forward, again, to make a difference in patients' lives. And so finally, again, I just want to show this last video. This is a whole room full of fellows and trainees that are going to be the future of limb salvage in our country, and every single specialty is represented right there. And again, when I was in training, this did not exist. I didn't interact with other specialties at all. And so I think that we're hopeful. If we can continue to do this, I'm hopeful that we will truly make a difference in limb preservation and disparities. So I'd like to thank you guys for your time.
Thanks, Dr. Fisher. Very powerful talk. I think in this meeting, we all believe in collaboration. I think there's a problem with it. I think that in some places you don't. And I think we all have to get out of our echo chambers and really start listening to what's the best for the patient. Along those lines, how do we do it? I'll start with the panel. Start with Dr. Quiroga. How do we do that?
I think that the first thing is to put the patient in the center. And sometimes my skills may not what the patient needs. And even discussing the cases with other patients, that's what we all like to come to VIVA, because you learn so much for other specialties. And also not only in the clinical practice, but just not thinking about politics, thinking about calling your representative. That's all putting the patient first and thinking how we can move the needle to a better outcome.
I think at least for vascular surgery, I think we're just talking to ourselves. It's a group of about 300, 400 people, and we just talk to ourselves at conferences. I think as opposed to having a representative from the Western to the SVS and from the SVS to the Eastern Vascular Society, why don't we have a representative to the ADA? Why don't we have a representative to the podiatry group? Why don't we have a representative to cardiology and vascular medicine and have them sit on our boards? But instead, like I said, we're just talking to ourselves over and over again, and our message isn't getting anywhere. So that's how I think collaboration could start at the society level.
Dr. Beckman.
I want to make one point which seems obvious but doesn't really get talked about very much. There's always a much broader national pledge of collaboration than a local pledge of collaboration, and I don't think it's actually anybody's fault. I think we live in an environment where our leadership puts us at competition because they prioritize your RVUs and not patient outcomes. So I think the other thing we need to think about is how to figure out ways to modify, attack, change the system so that the patient is actually at the center of the healthcare system and not how we are tracked for our workload. This was part of Dr. Rowe's talk on the other day, trying to figure out how to pay to make a CLI team. But the only reason we have to think about how we have to pay for a CLI team is because the doctors are under pressure. Not that anybody doesn't have an idea as to what to do for the patients.
I guess I would add, I still think that accountability is key. I think so. Dr. Rowe brought up that we continue to talk to ourselves and we have all these great ideas. If you take a STEMI, someone has an MI, and you take them to the cath lab at 91 minutes, you get dinged for it. If you take someone's leg off without doing an arteriogram, no one cares. It seems like it's a normal thing. And then it's still that amputation. Okay, we could even do better from that standpoint, and not send interns down. I remember being an intern they'd go down and say, take care of that amputation. And I'd read about it, I'd seen a couple, but is that really the best thing for the patient? No. You need to do a high quality amputation, get them in a prosthetic in 6 to 8 weeks, and make sure that they're ambulatory. We know that's how they remain functional. And so I don't think that people necessarily want to be held that accountable. However, if you really want to move the needle, if every hospital you had to document every amputation and document whether or not a vascular workup was done, I guarantee you the amputation rate would go down almost instantly.
I'd just like to really amplify something that Dr. Beckman just said, talking about collaboration at the local level and what makes people feel better. I think about impediments to advocacy. Nothing we do feels like it makes the local environment feel any better. It doesn't feel like a better place to work. It doesn't feel like any of those barriers are coming down. What does feel good is having great collaboration. I was looking at Sahar Sabri, who helped train me. We overlap. We were a wonderful, wonderful partner over time, immense clinical respect. But those are the situations that make you feel like you're part of the A-team, like you're providing spectacular care for patients, like you're really putting it all on the table. And that is sustaining. The same way that coming here and listening to you all and talking reminds you why you go back and fight some more for this stuff. But I do think that in advocacy, yes, we need to put the patients first, but we also need to look at things that sustain our colleagues and their local environments and that will make people feel better in their day-to-day lives at work. Some of that has to do with compensation, RVUs, incentives, and resources at the institutions, but they're incredibly important.
Well, that's a wonderful way to wrap it up. And I think that this session, again, it's iterative. Let's see what we come up with for next year as far as progress. We have made progress. When we started this 3 years ago, many people were on this panel. you know, it was just, what are we going to talk about? And then now we're finding things, and I think we're making some progress, and conversations are happening. But I'd like to thank everyone on this panel and thank the audience for being here. And we'll move on to the next.